Thank you for the honor. It's going too fast. Can I go back a few slides, please? So I have nothing to disclose. And so the surgical management of rectal cancer has been revolutionized by Professor Heald when he described the concept of total mesorectal excision. And since then, we know that high-quality surgery is essential for optimal oncologic outcomes in rectal cancer, and all surgeons should be striving for a complete or near-complete mesorectal excision combined with an uninvolved circumferential resection margin and an uninvolved distal resection margin. So operating in the confined spaces of the pelvis is already challenging by itself, and unfortunately, there's both patient factors and tumor factors that make this challenge even more. These risk factors have been associated with it being predictive of poor specimen quality, and as such, this would make the oncologic outcomes even worse. So it was hope with laparoscopic surgery that the oncologic outcomes would be improved, and several randomized controlled trials such as the Colorectal II and the Korean trial had provided evidence to support that there was equivalent oncologic outcomes comparing laparoscopic rectal cancer surgery with open rectal cancer surgery. However, the enthusiasm for laparoscopic surgery has been tempered by several large randomized controlled trials recently that showed that it was unable to show non-inferiority with laparoscopic surgery compared to open. So there's been studies that showed a relationship between MRI pelvic measurements to oncologic outcomes, and it's hoped that using these pelvimetric measurements that we can identify at-risk patients that would lead us to use a different technique that compared to laparoscopic surgery so that we can decrease these risks of poor oncologic outcomes. So the objective of our study was to do a retrospective review of our institutional results. We want to ask the question, can MRI pelvimetry predict poor quality surgery in patients undergoing laparoscopic lower anterior resection in mid to low rectal cancers? After ethics approval, all laparoscopic low anterior resection for mid to low rectal cancers, which is defined as being equal to or less than 9 centimeters from the anal verge, that had a pre-op MRI at our tertiary care center from the years 2011 and 2017 were included. We excluded patients that had recurrent rectal cancer and patients that needed an abdominal perineal resection, or TATME. Information on patient demographics, preoperative staging, operative details, and histopathologic details were collected. The majority of the MRI pelvimetry was gathered on a sagittal section of the pelvis, and based on bony landmarks such as the pubic symphysis, S1, S5, and the coccyx, various distances and angles can be objectively measured. The primary outcome was defined as poor quality resection, which is a composite of incomplete mesorectal excision grade. It involved circumferential resection margin and it involved distal resection margin. Secondary outcomes include the need for open or hybrid TME dissection and the length of the OR. Depending on the data, either the chi-squared or a Fisher exact test was used to analyze categorical data, and a student t-test or a Kirschko-Wallace test was used for continuous data. Exploratory factor analysis was used for data reduction and to identify the most relevant variables to be included for a logistic or a linear regression modeling, and statistical significance was defined at being less than 0.05. Here are the characteristics of the patient cohorts that were dichotomized based on the quality of the excision, good quality versus poor quality excision. As you can see, there's no difference between the two groups in terms of the mean age, gender, BMI, comorbidities, the preclinical staging, as well as the use of neoadjuvant chemo or radiation therapy. Looking at the mean interval between radiotherapy and surgery, the operative time, the need to do a hybrid procedure for the TME dissection, as well as conversion, there was no difference between the two groups. The median blood loss was also similar, and the mean tumor size was the same. The only difference between the two groups was the poor resection quality group had a higher proportion of patients that had a more advanced T-stage tumor. And here are the MRI pelvimetry variables that was gathered. And based on factor analysis, there were two variables that were indicated as being relevant to be included in the in the regression analysis, and they're highlighted in red. The first one is the distance between the top of the pubic symphysis to S1, which is the line A to E. And the second one is the angle between S1, S5, and the bottom of the pubic symphysis, which is defined as the angle ABD. After adjusting for the pathologic T-stage, BMI, as well as the tumor height, the multiple regression analysis that were performed only identified the angle between S1, S5, and the bottom of the pubic symphysis as being significant with an odds ratio of 6.2. So we've shown that there is an association between pelvimetric measurements and poor quality excision in patients undergoing laparoscopic low anterior resection for rectal cancer. And this angle, S1, S5, in the bottom of pubic symphysis more than 74 was independently predictive of poor quality excision. So this would allow us to selectively use other techniques such as TTME or robotics to mitigate the risk of a poor quality excision. So looking at the literature out there, there is kind of equivocal data to support the use of pelvimetry. These several studies show that there's no evidence to support the use of pelvimetry. The volume of a rectal tumor was not associated with oncologic outcomes, and it was not associated with CRM positivity as well as the difficulty of surgery. There's also evidence that shows that pelvimetry is associated with a degree of difficulty of surgery. These two studies show that a wider, more shallow pelvis would decrease the difficulty by decreasing OR time and blood loss. And then there's also evidence to show that pelvimetry is associated with the quality of resection. So the angle between the pubic symphysis and S1, or the distance between the pubic symphysis and S1, is associated with the quality of the TME, and as well the distance between the interspinous diameter and the acute promontory subsacrum angle was associated with increased CRM positivity. So in conclusion, we have shown that pelvimetry can identify patients at risk for poor quality mesorectal excision in laparoscopic low anterior resection. We identified this angle being an independent predictor of poor quality resection, and these patients can benefit from an alternative approach to improve the quality of the resection. So there are some limitations to the study, one being that it is a retrospective study at a high volume colorectal surgery institution, so the results may not be generalizable to other institutions. Also, we had a relatively small sample size of 92 patients. This would limit the number of covariates that we could include in our regression model without risking overfitting. And also, there was no routine restaging MRI after neoadjuvant therapy that would alter the clinical stage and the pre-treatment CRM, or sorry, the after-treatment CRM involvement. Thank you.
This paper's open for discussion. Would you mind, Dr. Chau, going back to your slide that showed the description of the angles graphically, just so the
Sure.
audience can see? I think it went pretty quickly, and I'm sure I wasn't the only one. And while we pull that up, I noticed you did have a long list of what appeared to be mostly bony landmarks. Were there any soft tissue factors that made the initial list? For instance, the ratio of mesorectal fat, say, for instance, compared to the pelvic diameter?
Yes, actually, originally we did include the volume of the mesorectum at one particular slice. However, on analysis, it was not significant, so we didn't include it in the final analysis.
And then as a follow-up, you had mentioned that your preliminary analysis showed a correlation between the height of the top of the pubic symphysis to S1. And was that the bigger that got, the more challenging, or the smaller it got, the more challenging?
So for the univariate analysis, the top of the pubic symphysis to S1, line AE, was important in the factor analysis. However, in the regression analysis, it was not found to be important and not related.
And understood, but on your univariate analysis, just for curiosity's sake, was it the bigger or the smaller it was?
The bigger it is, the better the resection quality.
The bigger was the better resection quality. Any questions from the audience? Well, I think I can speak for many people sitting in the audience. I think you did a great job putting some numbers to something that we've all realized and had a real difficult time describing. So thank you very much.
Thank you. My pleasure.